my informative speech, I've decided to talk about what I do for a living. I'm a neurophysiologist for NuVasive. Neurophysiology in NuVasive or anywhere is intraoperative monitoring, neurointraoperative monitoring. What that means is when we place implants in the spinal column, we want to protect the spinal cord from any injury from the actual surgery. We can do simple procedures that can help patients in the long run. We monitor the sensory pathways and the motor pathways, as well as an EMG during the procedures. This can give the surgeon live feedback on what's going on neurologically. When we're placing screws per se in the spinal column in the lumbar region or in the thoracic region, we can run SSEPs, which is the somatosensories, your sense of touch, to make sure everything's still going okay. We're not feeling any numbness. We also run an EMG, so we could directly stimulate the screw. We'll send a current into the screw, make sure that the resistance is good, making sure that that screw isn't too close to the spinal column, the spinal canal, I'm sorry, and not causing any nerve irritation. If the screw is breached, if it's too close to the spinal column, it'll send a signal down to the leg muscle, associated leg muscle, such as your calf muscle. If we pick it up there, we'll go ahead and we'll inform the surgeon that there is irritation in the nerve, and he'll reposition the screw. This helps a lot because if there is a breach into the spinal column, the sooner you fix it, the sooner you move that screw out, the higher probability is that the patient will recover from this. This is my son Dominic. He's going to go ahead and he's going to assist me today. We're going to go ahead and demonstrate more or less what we would do with a patient. He's going to be my patient today on neuromonitoring. This is a piece of equipment that we use during neuromonitoring. It's called the NVM5. It's specialized equipment by NuVasive, exclusively for NuVasive. There are other computers and devices that we would use in neuromonitoring. The most common one would probably be the Cadwell. It's called the Cascade. It's another piece of equipment that does almost the same thing. But this is my favorite. This has simplified neuromonitoring. This has made it easier and made it better just for patient care. So this is the NVM5. There's different setups we can use, and I'm going to go ahead and I'm going to show you on Dominic on where we would place our pads and what we will actually be looking at while we're monitoring. So today we're going to do a basic setup for ACDF. That's an anterior cervical disc fusion. I'm not going to do a full setup because that would take a lot of equipment that I'm not going to use on that for a demonstration. But we'll go through the basic ones right now. So during an ACDF, we need to monitor the sensory pathways and the motor pathways for the procedure. Sensory meaning your sense of touch, and motor meaning your sense of movement. Okay. Of course, the patient's asleep when we're doing the procedure, so we can't ask the patient to move or if they're feeling funny during the procedure. That's where neuromonitoring comes into play. We go ahead and we try to prevent injury from the actual procedure. How we do that is we're going to monitor the sensory pathways using these. These are specialized pads that we use on the patient. That'll pick up the responses. Or actually, these will actually send the response. We'll stimulate for an ACDF, we're going to stimulate at the median nerve. So we'll get a little patch. We'll put it in the middle of the wrist. And this will send a stimulant activating his median nerve, going up through his nerves, into his spinal cord, and then up into his sensory cortex, primary sensory cortex. And we'll pick that up with our equipment. That's for his uppers. We still gotta do his lowers to make sure everything is working in lowers. The way we do that is we'll go ahead and we'll be working at the legs. One step I forgot is you're supposed to use an alcohol prep pad to clean off any oils or dead skin. And this is to get a better read. So I'll clean off. And this is the PTN, posterior tibial nerve. Same thing, it monitors the sensory pathways. So place one. And place one. This will help monitor the sensory pathway. We'll also place some needles on the head, but of course we're not going to place needles right now. He's awake and he'll feel pain. Generally, the needle placement, it's going to be needle right about here, needle in front. This is a CZ and FPZ. Okay. And then C3, C4. And then we'll place another one in the back of the neck. That's for the cervical. These act as gateways when the signal goes up. If it reaches the cervical region, we'll get a response on our computer. It looks like a little waveform. It's telling us that it has reached the cervical region. Okay, and then it'll come up and it'll record on the head. It'll be cortical and subcortical. So we'll know that it's reaching the central. I'm sorry, the primary sensory motor, the primary sensory cortex. Okay. Motors work similar. We'll stimulate at the primary motor cortex at the scalp. It'll send the signal down, and it'll pick up at the hand on some needles. We'll go ahead and we'll pick up the response there, or at the feet with some needles, and our computer will let us know if we are sending the signal that's going down the spinal cord and everything is connected. The next thing that we'll be doing also, and it's working similar, in a cervical, if we're saying we're working on C5, the primary muscle that's associated with C5 of the neck, that's cervical level 5 of the vertebral body. If we're working at that disc space, we're going to remove that disc space. We want to make sure that the nerves aren't being touched. One of the primary muscle groups for that is the deltoid. So we will go ahead and we'll place a patch on the deltoid. Again, we'll clean the area, make sure everything's fine. The best thing, there's two different ways we can do this. We could either use patches or we could use needles. I'm using patches for now so that we don't stick my son with needles. Okay, and we'll place that there. So if we have any nerve irritation up at C5, it'll send a response down to the muscle at the deltoid, and this little patch will pick it up and it'll send to my computer in an EMG that we're running. If we see some firing on the EMG, then we know there's irritation happening at the nerve. So now we're going to talk about some of the equipment that we'll be using. We'll be using the NVM5, and we'll be selecting our program that we'll be using. So this one's set up for a lumbar. I know we had talked about cervicals, but this is set up for a lumbar. It automatically populates the muscles that are recommended, but we always run into a case where we're not working at these levels, so we have the option of changing it also to muscles that accommodate this. This is the sticky pads, of course, that pick up and send signals. We have a head harness also. A head harness. It's 6 needles that go in specific spots so that we could pick up SSAP responses, which is the sensory responses. This is the patient module. This is where our harnesses are connected to, where it hooks up to specific locations on the body that'll help us monitor. These are labeled for quick references because there's obviously a bunch of colors that we would have to memorize, and everything is specific and it needs to be connected in a specific way in order for this to work. It's a quite complicated system. This is where the head harness would be connected, and this is the responsibility for the sensory pathway, and this harness is responsible for the muscle activity, the EMG. Okay, we are connected online so that we can speak to a neurologist. The neurologist will help us out and diagnose any issues that are going on during the surgery, if any. If anything happens, he'll make his recommendations, and we'll pass off that information to the surgeon or the anesthesiologist so we can make corrections, so we can get our responses back, or correct things that are in the surgery that may have not gone so smoothly. What we just talked about is just the tip of the iceberg. The NVM5 has made it easier for us to monitor, but it's a very, very complex system. It's not a simple job. You have to learn a lot to understand what's going on. Simplifying it doesn't mean that it's easy. You need to understand what's going on. We need to understand what these numbers are, and we have to talk to multiple people in order to make sure that this patient's safe. I really enjoy my career, but sometimes just remembering what we're responsible for is shocking. It's like, wow, this is what we're protecting. I hope that this informative video has sparked some interest in you, and maybe you can learn as well and become a neurophysiologist as well.